Okay, so I'm literally most people that don't know me already. So I'm just going to run through just a few slides just about things to bear in mind for the exam when I get into it.
So for the second lecture, can you just leave them for a second? There'll be plenty more, don't worry.
Everyone's so into paperwork. And then I'll just a few sort of common things that you might find on call, and that's just useful for getting into the way of thinking that makes you do well in the integrated, really, and the and then there's a slideshow, so you can go through that. So integrated, as you all know, it's even fewer questions than it was last year, so that means that there's even less time for them to ask ridiculous questions, so it is just going to be sensible stuff, because in order to make sure you're safe, they can't do the ridiculous questions as well, and make sure that you've got all that basic level of knowledge. So stick to syllabus, go through all the core conditions, ask yourself those 4 questions, because that's what all the questions are based on. They're either like what you would do, or what you would do first, or what test would be most likely to be diagnostic, or what the final end point in the management is. So you've just sort of got to make sure you read the question properly, and if you've got all that to mind, if that's the way you've been thinking about all the core conditions in those 4 ways, then it's all going to be like at the front of your mind, and you can just like tick through the answers, and it's going to be easy. Obviously, if you don't know, just don't have it. Most of the questions just need you to be sensible, so if you find one you don't know, you can just move on to the next one, which will be really easy. It was ridiculously easy. Like, it's just you've got all this knowledge, and you go through, and you're just like, oh my god, I know this. I know exactly the dose. I know the mode of how quickly it needs to be infused on an IV infusion, and then they don't ask you any of it. They're just like, the answer's fluids, and that's it. It's really frustrating. You come out being like, oh, what's the point of all that revision? Well, I guess you've got to do it to make yourself feel better about it. At OSCE, just practice, like practice. Like, you know all of the stations that are going to come up. So realistically, you could have done them all, like, 4 times over if you just get yourself in a group and go through them. That's what we did. We made a really sad OSCE camp, which was really fun between the 2 exams, and it just worked really well because at the end of it, we were doing like 16 stations a day in our group of like 8 friends, and it was fine. And so we'd done them all, and there wasn't any surprises when we actually came to the day. Everyone has a nightmare on a station. There was the girl in our year who decided that she'd sort of beaten the system. She was like, oh yeah, I've not seen this patient in the last 7 days, so didn't fill out the death certificate, didn't do anything, just sat there in silence, didn't do any of the station at all. Thinking she was so snug, all the examiners were like running around outside, being like, what do we do, do we tell her? And so she didn't fill in any of the death certificate, didn't do anything, thought that she'd like won the marks, and then realised at the end that actually the whole station was a death certificate, she didn't get any marks at all. But she still passed, and she still did very well, so don't worry about it if you've won the station. The examinations are really easy marks, so just nail them, because it's like stations to get 100% on, and you know exactly what's going to come up, so it's fine. Slideshow, just again be systematic about it, like in this last bit of revision, just think of all the conditions. You know that the slideshow are going to be based on those core conditions, so think of any like possible ways they could display things in images that they could ask you questions on. So make some slideshows, share them between yourselves. If like the answers are detailed, it's quite good for your theory revision as well. So that's what we ended up doing. By the time we were just like ready to shoot ourselves with revision, it's quite nice just to sit and go for a slideshow, which is pretty sad state of affairs. ECGs, ABGs, they're a given, so they're definitely going to be on it. Imaging is obviously really easy, so like bearing swallows and chest x-rays and stuff. And then the rest is just completely random, so you just sort of, you either know what you don't, and some of it's ridiculous. There's always a rectum of some description at the end. It's like Fuller's idea of a joke, I think. So if it's the end and you were questioning, like one of the guys in our year was, whether it's a rectum, a prolapse rectum, or whether it's a penis ridden with gonorrhea, go for the rectum. He went for the penis, and it's actually a prolapse rectum, so I don't know what he looks like. So I just did a bit now just about sort of moving on from here, and that sensible way of thinking. So I've just got a few of the things that you get really commonly on calls. I think you noticed like an on-call scenario lecture last week, so I just thought I'd put some in because it's the stuff that's really useful at the end of the day. So the first on-call is rubbish. It's terrible. It was my first weekend, and it was like the worst weekend ever. But they do get better, and then it's just going to work, isn't it? So make sure you're organised, keep good lists, work systematically through it. S-bar is something which might come up in your OSCE. It's just like they're mad for it at the moment. It's like a detailed handover and the nurses are rubbish at it. They just don't do it. So just try and get it out of them, otherwise you get a handover from a nurse being like, doctor, I need to see them now, I need to see them now. They don't even know the OBS, they've not done the OBS since 9:30 in the morning, and you get there and you're just like, what are you doing? Like, this is stupid. So, yeah, just remember that, because it seems to come up a lot, because they love it at Leeds. So, common problems, surgical. So the first scenario is just a man of 65 years old, he's had an subjectomy yesterday. Doesn't have any significant past medical history, he's got an epidural in for pain control, which is working well. The nurses call you and they say, oh, doctor, come right now, BP's 79/40. They're flapping about it, the urine output's low, they're really worried, and so what do you do? So does anyone, what do people do?
ABCD.
Yeah, ABCD is always the answer. Get the other OBS, obviously, that will help to guide you in your management. You can then run through all these causes of low blood pressure, so you can start to get that from the OBS straight away, and then you move on to the history. So he doesn't have any significant past medical history, so you're not really going to be led down sort of all that sort of causes. He's not had any intraoperative complications, he's not got any pain, he's completely asymptomatic, so all he's got is this low blood pressure. So in the examination, it's all up there, the important stuff you look for, so I won't ask you. But obviously, volume status is really important, so you just need to know whether he's euvolemic, whether he's, volume deplete, and then you'd be pretty well guided as to why he's got low blood pressure. Look at his wounds. If they're leaking loads of gunky fluid or blood, then obviously you're going to be a lot more worried than if they're just nice and clean and dry, normal post-op wounds. Look in the drain bags. Is he losing loads and loads of fluid from drain bags? GCS, if his GCS is 15, you're with a low blood pressure, you're obviously going to be a lot less worried than if his GCS was 3. Look at his epidural site, check that it's not sort of red or inflamed, check the epidural's still in, because then it might be a bit of a red herring as to why his blood pressure's low if it's actually fallen out of his bed. Do a PNS to see where the block is, because if it's up here, that's obviously worrying. Look at some further investigations, so just look on the results server straight away, and then you know if there's there's been a big drop in their haemoglobin, then they might be bleeding. If their inflammatory markers are up, probably septic. Get an ECG if you're expecting that maybe there's a cardiogenic cause. So then fluids-wise, do you all know that you're quite confident with fluid challenges and stuff like that? Yeah. That's just so many fluid challenges, it's ridiculous. Everyone always says it's a bit cautious with them to start with and says that, 250 and then another 250, but generally, unless they're a really frail old lady or someone with really bad heart failure, they can just take 500 ml stat and just knock it in. Otherwise, you don't really see much with 250, and it's half a bag, and then it's hanging there for ages, and the nurse can't give it the rest of it, and then it goes off. So it's better if they can take it, just give them the 500 ml. Assess their response after it. If they don't respond, then try it again. Keep trying it until they do respond, or you start to think of other causes, like it's a cardiogenic cause to it. And then make sure when you've done a fluid challenge, because then you're going to get really busy, so make sure you prescribe all the maintenance fluids so they don't just then get really dehydrated again. So generally, Dexaline is really good because it's really cheap, so everyone likes you to use it really, rather than people say Hartmann's and things, but Dexaline is really good, so just 8 to 10 hourly bags of that. Make sure you check using these plus potassium. Catheterise them if you're worried about the urine output, make sure they're on strict fluid balance. It's really hard to get nurses to do strict fluid balance, so make sure you explicitly say, I need to know how much urine is coming out, otherwise they won't do it. Consider the epidural, make sure you ring seniors about things when senior call is necessary. So with an epidural, you obviously wouldn't slow the rate yourself, but it might be necessary if they've got an uncontrollable low blood pressure, they might need it slowed down. Always when you're assessing someone, get into the habit of reviewing your drug chart. It's really easy to forget, but if you see someone with a low blood pressure, make sure that they're not going to get their blood pressure meds 2 hours later and drop the blood pressure down to 40 or something. Regular odds, and then just write re-review if it deteriorates, because then you've covered your back and they know that they can just call you if they need you. So that's pretty easy. Obviously, you just need to work with a systematic approach to going through all the causes. I'm sure you'll know that by now. Same with pain management. I imagine flogging a dead horse a bit, going through pain management with you all now, am I? with the ladder. So obviously, make sure you assess and you pay. And it's really easy when you're on call just to ignore it and just to be like, oh right, you know, write the next step on the ladder on the drip chart. But try and assess it. Try and make sure that it's the same pain as they have been having, and you're not missing sort of, you know, some central crushing chest pain or something. If it is the same pain, then just make sure you step up the ladder sort of one step at a time, unless it's something that you know will require, you know, a lot of analgesia, like an MI or something. And always give yourself like more to work with. So start the lowest dose, because they'll just bleep you again, and then they'll want the 100 milligrams of Tramadol or whatever. If you've only given them 50, you can then say, oh yeah, look what I'm doing now, I'm increasing it. So it just makes your job easier. So do that. Always think about the route as well. It's easy, especially in surgical patients, to not think about it and write some coding up, and they can't actually have it, so then they just go without any pain relief for the whole night. Temperature is just the bane of your life, because you get the obs round and they ring you, like you get 15 bleeps because everyone spikes temperature. So you have to sort of weed through them and pick which ones you're going to see. So generally, if it's below 38.5. And it's just a nice dose temperature, I just leave it. I get them to do regular obs and just see how it goes. Obviously, if they've had temperatures before and they've been cultured and you can see on the system again, you can just sort of leave it. Watch and wait, give them paracetamol. Above 38.5, if they've got other abnormal obs, then you obviously go and assess them. So this one, if she's 4 days post-gastrectomy, get a call because she's got a temperature of 39, she's also tacky, but she doesn't have any other things on her obs. So you obviously, again, work systematically through it, so finding the source, go just through all the systems. It's quite easy then just to sort of whack out a temperature assessment, because if you just working through all the systems, you can just write it out really quickly, assess them really quickly, and then it's just done and you don't miss anything. Obviously, don't forget sort of iatrogenic causes, so any indwelling lines, catheters, wound sites, drains, make sure you get swabs and cultures and things from all of those if you can. Full history, full exam. And then your septic screen, and I guess you all know SIRS, sepsis, all of those guidelines now, do you? So I won't go through those, but the sepsis 6 is something that they always go, there's stickers now, which are often a bit unnecessary, because you know, some of the stuff you don't want to do, like you don't want to whack a catheter into every person that you've taken blood culture from, but it's worth considering it, and the sticker's good for that. So making sure they're on O2 if they need it. Blood cultures, starting with antibiotics, ideally within an hour of someone being septic. Getting a lactate and a full blood count, which is quite easy to forget. Making sure they're on IV fluids, catheterise them, or make sure you've got strict fluid points if you know you're going to hold off the catheter for a little while. So, any questions, or anyone want to know anything else about any of that stuff? Or any other scenarios or anything that you've been wondering about? So I'll just crack on then. Everyone all right to start? I'll try and move through them fairly quickly, because I know it gets boring if I'm going too fast, just stop me and we'll go through them. We learned loads of dermatology things for the slideshow, because it's like, you think that that's a really easy thing to be pictured on, so you imagine that it's going to be really derm heavy, but it's really not. Like, I don't actually think there's anything dermatological in it, but if there's anything that seems to come up, it's things like this, which are those like classical signs. So did everyone know what it was?
Do you reckon they care much about the spelling, or if it sort of looks right?
I don't think with something like that they can't really spell it right. So that's just, it's quite common in especially young women with diabetes. About 50% of cases of necrosis avoid colitis in diabetes. It's usually the classical picture of it is like the one that we have in thyroid disease. It's like the shins and the lower thighs. It's pretty nasty, shiny looking. Generally, if it's on someone's lower legs, you can take a guess that it would be one of these things. So treat it with corticosteroids or immunosuppression if it's really nasty and ulcerated. So what does this age show? So, does anyone know what it is? What it shows? Sorry, do you want me to ask you the answers or shall I just tell you?
Type 2 spiritual and mixed, that's a bit.
Yeah, it's like it's mainly respiratory with a partial metabolic compensation, so it's not fully compensated because it's not quite got back up to normal. But yeah, so what would you see that in? What would that be typical? Yeah, so like you know that there's something chronic going on if the bicarbs start to rise like that. So when you're looking at the ABG, obviously asking the first thing you want to know is really are they hypoxic, because that's the sort of thing that's really going to sort of kill them in an acute setting. So are they hypoxic? So just get them out of the way then, they can either be on oxygen or not. Is the pH normal? If it's abnormal, is it respiratory or metabolic, or is it both? So it's quite good to look at the base excess, because that's sort of if the CO2 is normal. So then you know whether or not there's sort of metabolic component either through compensation or through sort of some renal problem. And then is there any compensation for it? And it's worth being familiar with, I'm sure you all are by now, but they do come up a lot, so it's worth knowing. Anyone know about this? I don't really know what that second, ignore that side, it's just, I'm sure that shows something, but I don't really know. Anyone know?
Ventilator.
Yeah, stabilizer. It's quite like one of those typical variant swallows. It's quite good. Tell I'm getting pretty rusty. only wrote this presentation about 2.5 hours ago and I've already forgotten it. Anyone know what it is? What condition? Yeah. What else is associated with C? That's stereotypical associations with it. That's the bottom, you guys yourself probably answer the reasons and I'll try. It's not very common, really. It's around 1 to 4%. Anyone know what that is? It just says that it's a 54-year-old woman with small cell lung cancer. She's presented with nausea, vomiting, polyuria, excessively thirsty, and she's got leg pain. And that's X-ray. And it just says at the bottom, what's the diagnosis and what's the appropriate management it should say. Which apparently is meant to mean polyuria because she was sitting on the toilet. It took me quite a while to find that out from Wikipedia. But that's what the last one is. It's quite cryptic, but at least in my own able to make it. The main treatment is rehydration, not sort of jumping in business names, but they obviously are the main management. Down from the side. This is like a massive one, and even if you can't see the 5 things, then just say you can. So what is it? What's the diagnosis? I hate this like teacher so many people. Yeah, heart failure. So what are the 5 things that you need to say you can see, even if you can't, or at least look for? Yeah. Yeah, that's it. So A, B, C, D, E, useful, mnemonic, to learn more about. And quite often you can see all of them, which is like surprising. You could actually look for them and see them. It's not like, you know, in osteoarthritis and things where you just see them, you definitely can't. You actually can in heart failure. So what signs would you get? Obviously it's there. So just like look out for the signs of it. do all the investigations, so all the usual ones, full blood count, knees, ECG, echo, ABG, because it might be profoundly hypoxic and actually really symptomatic with it. The natriuretic peptide is one that everyone talks about, doesn't really do, but I think that's one that technically you can do on X-rays. Common causes, obviously post-MI, some ischemia. If someone's got really malignant uncontrolled hypertension, any form of sort of valve disease, aortic stenosis, aortic incompetence, mitral incompetence, like arrhythmias as well, if you sort of really fast AF and you just don't have the output. So treatment-wise, obviously the ABCDE normal treatment, 100% O2. Make sure you've got IV access. Make sure you've checked whether or not they've got any arrhythmias. Like one of the most commonly missed causes of sort of an acute exacerbation of heart failure is like an MI, and you get so bogged down with all the, all the respiratory stuff that you forget to do an ECG, and they've actually had like a massive STEMI and you didn't know about it. And that happened to me in like my first week. I missed it, which is bad. And then through MI, you just sort of go by their blood pressure. So if generally people can start at 40, you can just titrate it up until they get some proper symptom control. Obviously, if it's dropping their blood pressure, then you need to stop and be guided by their renal function as well. Morphine's meant to cause a bit of respiratory depression, makes them ease their agitation, and it's better, obviously, not for everyone.
If you have a question like that in Slideshow, how much of this management do you think you should be writing down?
Oh, not all of it. It's just because it was such a big topic, I just put a little bit extra in. But
would you just put the drugs that you would use, or?
It generally says in the Slideshow, like asks for a couple of words or something. Like there's two spaces really, so you can't really write that much because it's got 2 bits, or it's got like a few lines. So you're sort of pretty guided, I think, in the Slideshow by how much space they give you as to what you need. But I wrote so much stuff, because I like writing it out. You don't want to miss anything out. But, I don't think it was necessary. It says how would you manage it at the bottom. Or what is it as well as one of the questions should be on. I think it's a lot better picture on my, where it's a bit small on the screen, it's a lot better, it doesn't look quite as defined. Does anyone know what it is? How do you manage it? And what's sort of the big, along with managing it with NSAIDs, what do you need to sort of be careful of? What's it at risk for? Classically pancreatitis, but obviously it can be caused by anything that causes things like fracture, protein, so acute pancreatitis, they're just some of the causes, I'm sure you all know. What is it? Management varies between, you talking about it, which guidelines they're using, but generally morphine, oxygen, nitrates, aspirin, clopidogrel, fondaparinux, and then whether or not they go to PCI or thrombolysis, or just depends what centre you go to. Within 24 hours, you should start on all sorts of secondary management like beta blockers and ACE inhibitors as well. They like run across. There's sort of the two blocks like before. So what's the management of A?
What is it?
Huh? Okay, what is it? What is it? You know what it is? Yeah. So yeah, the A is just the vein's not compressed because it's full of clot. And B is compressed, so you can't see it. So it's just like the ultrasound of the vein. So how would you manage it? Yeah. How long do you continue the therapeutic dose?
6 months? 2 weeks?
Yeah, you like start them both at the same time. You don't have any contraindications to warfarin, you start them both at the same time. But you have to continue the low for at least, I think it's like at least 3 days. Because there's a period when you first start warfarin where that's hypercoagulant. And you need to obviously keep it until warfarin therapy soon, so that's often longer than 3 days. And then the duration of it obviously depends on whether it's provoked, whether it's unprovoked. So it's usually 3 to 6 months, or life if it's been a second unprovoked GPT.
Do you think we need to know the actual days?
No, because it's just dependent on weight, and you just go from the chart in real life. Real life, I think it's, and it all depends on which low molecular weight heparin you're using as well. So I don't think they'd expect you to know. As long as you know that you work it out by weight, and you know where to find it. I don't think you need to know. Compression stockings as well helps reduce the risk of post-DVT complications, so try and get into where those IVC filters So this is an arrest in resus. That's ECG when you get there. So what is it? So what would the management of that be? Do you know what the difference with the sort of shockable, non-shockable alcohol?
Straight away.
Yeah, as soon as you've got IV access, and then just every 3 to 5 minutes, rechecking the rhythm every 2 minutes until you get a shockable rhythm, until you call it. So what do you do while you're doing CPR? You do all the reversible causes, so that's something that you should roll off the tongue, really. So you just run through them all, and once you've ruled all those out, if you've still not got anywhere, then it's probably time to pull it out. Can you see the bottom? This is the
17. What are her levels?
24-year-old epileptic presents after paracetamol overdose. 8 hours, the levels are 70. What's your hand? Can you read the numbers on the chart? Yeah, it's changed now. So I guess yeah, it's still a little bit redundant. This slide. But you carry on the treatment. Hypolepsis, the anaphylactic, you just carry that on until the LFTs are normal, or until the LFTs mainly goes by the INR. So if your INR is still abnormal, you just carry on running back to back 24-hour bags of Hypolepsis, and you just keep rechecking the LFTs and costing what you need. Obviously, get them assessed by site. Just get young to up straight.
Ian.
I've got more slideshows. Does anyone know what it is? Yeah, I think we're going to do partial. Although this is something I never really fully got, but I think you only need to know it in sort of the loose terms like that. That you either have a total which has got all 3, partial which has got 2 of the 3, posterior which has got cerebellar signs, or lacuna which is just pure motor, it's just lower, so there's no high functioning factor.
Don't worry, it's filled in slightly.
Yeah.
Carry on. Have you got more questions?
I've got loads of just like Yeah. Know two causes of it? Yeah. Yeah. What's the main cause? Most common one? Yeah. This is really bad. What did you say? How did you make it so Does anyone know what it is? This is a bit so like, there's little lights out of blood cells and rapid hematological condition. That's what it is. Should I start making these out? This is just like go on forever.
Yeah.
Really?
Can you download everything off your email?
Yeah.